Welcome back, ladies and gentlemen, for the third session of the day. I now invite Sir Moir Gray, Chief Knowledge Officer, National Health Service UK, and Dr. Santosh Babu, Managing Director, ELCOT, and CEO, E-Governance Government of Tamil Nadu. I request the chairpersons to please conduct this session.
Good afternoon, friends. Respected speakers on the dais and off the dais. I think a post-lunch session is always like this, to be expected. In the morning, we had a huge number of people here. In the afternoon, this was to be expected. But I'm sure we have a surfeit of speakers here, and to chair the session along with me would be Sir Moir Gray. He heads the the Knowledge Commission of UK, National Health Service. He's most interested, and he has also his own personal runs something called Value Care in UK, and his interests are in evidence-based decision-making. His other interests are patient-centered care and using information systems for better health. I request Sir also to join me in introducing the audience here.
We've got a star-studded lineup for you this afternoon, and we're going to hold them very much to 12 minutes each. And someone here is in charge of the big red light, because we're hoping to have time for discussion around the tables when the speakers are finished. And the first speaker is Retired Admiral Singh, who has been working for the National Health Rural Health Mission, and it's fantastic. They're developing in every village someone useful, namely a woman, from each village who is the accredited social health activist. I love the word activist, so would you please come and tell us about how you're going to support them? Would you like to come forward?
First slide, second I'll change myself. How
Yeah,
do I
sure.
change? Just by this?
Press this button.
Yeah,
sir.
yeah, that's okay. Good afternoon, ladies and gentlemen. It's a transforming rural health by information technology. In the same month in 2005, on 12th of April, National Rural Health Mission was launched. It was launched with the idea to give accessible, affordable, accountable healthcare to the 70% rural population of India, which is also, most of them are below poverty line. By one estimate, there are 42% population in India, we get less than $1 a day. So it was a concern that we are talking of the various kinds of Medicare, patient care, and the hospital, which are very hi-fi. Can this rural population look after? It can be looked after. We have 6 lakh villages around, 615 districts. So this National Rural Health Mission looks after district, hospital, and downwards. And as he was mentioning, the accredited social health activist is one picked up from the community, is trained and put forward. We are only putting 1.1% of GDP, which is in the budget has been increased to 2%, while many developed countries like US have given only 17% of GDP. We are one of the signatories of achieving Millennium Development Goal, and 2 of the important goals are infant mortality rate and maternal mortality rate. All that will depend on how we can take technology along and deliver this to the common people like this. We understand technology revolution you've seen in Middle East. You have seen very recently in India that such revolution can also be mimicked in the health sector. If we really see various initiatives, these are the 10 different initiatives. But since we have a federal system where the state looks after the health and education, where the center may fund some of the programs, but delivery has to be done by the state. So it has to be the rural-based, if you are talking, it has to be the district-based implementation and also below. The government of India is planning most of this budget of this NRHM, which really cannot be utilized every year, for such initiatives, including IT. But the states, they put it up. E-Mamta is one such initiative, which has been done by the government of Gujarat, where 80% of the population has been covered. It is all the pregnant ladies will be looked after under E-Mamta scheme. They have a data now with each individual, and Asha is one of the person who brings this data for bringing into the system. This data is collated and ultimately follow-up programs are done right up to 5 years when the child will become 5 years. From the pregnancy, antenatal, postnatal, including immunization up to 5 years, to reduce the maternal mortality rate and the infant mortality rate, two of the MDGs, Millennium Development Goal of United Nations, which we want to do it. This is a scalable model. It has been accepted by the government of India, and other states are requested to do it. We have 26 states and 9 union territories. The second issue which has been come up is telemedicine. But we find that may be one of these initiatives may be adopted by few of the state and still may not be applicable in each state. We are in the stage where we are at the bullock cart economy, also landing on the moon. So you would find different stages of development where such things will happen. Telemedicine, I happen to be done the first international conference on telemedicine, given J&K inaccessible areas, connected it as a pilot project. Apollo was another one, and some more which have come in the bandwagon. Karnataka had this, our state of Andhra Pradesh, and many more have now joined in how to give teleconsultations. Well, it is not replacing the human people values or the physicians, but an additional tool which can be taken care of. Integrated Disease Surveillance Project, IDSP, it is still in the infancy. It's a Government of India project, so that you would find that when there is group of patient, then epidemic starts. So somebody can call up the toll-free number, including the general practitioners or primary health center, and alert the center government, where the teams can go and start working on this particular issues. It is also in one of the infancy stage. GIS mapping, which has been done in Gujarat. Again, Gujarat name comes and again comes, but it's not politically motivated, I hope. And it is something which is already there, and we are doing it on this. IT, in one of the below poverty line insurance, which is also taken by the Government of India, chip card issued, and the beneficiaries are really taken care of. Medical supply chain applications done by Tamil Nadu, where needies will get the medicine as required rather than distribution not being proper. Medical call centers like HMRI in this state have got it, with the minister has already said, and it is a success story. Many states are applying it. Ambulance services like EMRI again in this state, 10 states have applied in different formats. ehealth, we are one of the signatories. We had a big conference, and this mobile telephone, 600 million people are subscriber. So they are being given to ASHA and other people, and taking that, they can be alerted that you are due for immunization, you are due for antenatal checkup. It is already happening, but not happening in the scale which is required. There are many newer initiatives. The Dr. Ganju is here in the crowd, who has also presented along with many colleagues how National Health Portal can work. Everybody is agreed. They said it will be implemented. He was a part of the Knowledge Commission, and today you have heard one of the things which are being done, what was the recommendation Knowledge New Commission. So maybe in future we will have electronic medical record. It cannot be linked up with the UID for first 15 years, because UID is being given for at the age of 15 years. But I'm sure gradually all these initiatives can be taken together. There's only one issue. I'm a physician, and there are hardcore IT people. So they have to come together. Gradually they are coming together, but we have not reached to the stage where it will be totally merged into. I would like to give an example. When I was a young medical student, family planning had just started. And I was talking about the family planning. I was a bachelor. My teacher, who had 3-4 children, was talking about also family planning. In the last, Dean said, there are two eminent speakers. One doesn't know what family is, and the other doesn't know what planning is, but they are talking about it. So that scenario has to come. We have to speak together in the same language for doing better in the rural initiative. Thank you.
Our next speaker is Dirk Dumortier, who is Belgian by background, but is working for a major company providing the spine, the infrastructure, to join together what we're doing. So, Dirk.
Okay.
All that matters is up there. I won't offer to help. Have you seen it on here?
Yeah.
There we go. This is a demonstration. Don't rely on technology, only on human beings.
Okay, good afternoon, everyone. I think it's for all of us a real honor to be here on this kind of speed dating sessions. It can only take 12 minutes. But as a telecommunication provider, oops, CD-ROM, what are we going to have here? Nothing special? No. Do I need to do something? I hope not. Okay. Maybe wait 1 more minute.
Comes on and off.
Why don't you put it on your phone, Dirk, and then everyone can just switch their phone on?
And follow it. That's a good idea. Let's try it.
Just leave that. Thank you.
क्या हुआ Chicken, it's my laptop. I'll just everything about this. You need to connect this, right? One second, let me just do it. अरे यार मेरा लैपटॉप भी मेरे को मालूम है ना डिस्प्ले कनेक्टेड it's there okay no yes
Good, thank you very much.
Well, let's hope technology is not letting us down for the moment. So let's start again. I hope I still have 12 minutes, but okay, that's something else. So before I start, just an additional welcome again. And what I'm going to talk about is about the spine of the digital healthcare delivery. Now, if you look about ehealth, it's for sure that going digital is no option. That's the way to do. It's going to be a long one and a painful one, but we need to get through it. If you look to APAC, and I have done some studies around the different countries here, in the next 10 years, we're going to be obliged to build between 3 to 6, some countries even up to 8 times the amount of hospital and hospital beds that we have today. Is that because of the aging population in specific countries? Or is it about the growing population? It is all to do with the economics and the growth of the economies we have here. Hope this is working. Okay. At the same time, and some studies in the UK and in Europe have shown that if you look to the healthcare and the hospitals, there is still a lot of silos. Silos that need to be broken up. And as healthcare is a teamwork, it's a pity to see that 60% of the medical complications comes from poor communication. Is it between the doctor and the nurses? Is it internal? Is it with the patient? Vice versa? What you need to take? It has to do, a lot has to do with communication as such. Also, 40% of medication errors come from an incomplete patient view. And that's a fact where the electronic medical record of health record becomes so important for. We also know that the things need to change. Based on what we have seen, we can never deliver the amount of doctors and nurses that we need. If you look to countries around us, they are all insourcing nurses and doctors. And by the way, that's a huge opportunity for people here in India who want to do the studies in healthcare, because there's a huge opportunity out there. But we see that changes are coming. Governments are trying to put their acts together. That hospital is not longer the center, but you need to take care about the whole integration, prevention, hospital and aftercare. And that's something who is coming. And of course, the whole issue will be in how we can bring, in fact, healthcare to the patient. Now, bringing healthcare to the patient himself can come from different corners. There is one toilet manufacturer in Japan, Toto, who came up with a wonderful idea to, in fact, make from the toilet a medical environment. It's a very scary thing. Instead of having the 5 minutes private time, no one is bothering you, now you need to take care and think about your health care. Very, very scary. But it can come from everywhere. So why not? Good ideas. If you think to the patient-centric journey in a digital environment, we know that the electronic health record is going to be the #1 issue. Everyone needs to have access to that. Okay, that's very important. And the resources need to be brought to the patient, wherever he is. And the collaboration is going to be a fundamental aspect of making it happen. Creating what is necessary, reducing the time, making it efficient for the doctors to help you, reducing the cost because the governments cannot longer pay for it, but at the same time increasing, in fact, the healthcare as such. This seems to be maybe a pretty complex slide, but it shows you that in the hospital themselves, there are multiple pathways, multiple flows, multiple processes that takes place. Now, of course, with the electronic health record, it becomes easier to have that single point of view. But between all the elements that you can see here on the slide, there are, in fact, communication points, points where people can collaborate with each other, points where your processes can be optimized. And that is where re-engineering needs to come from. And by the way, telecommunication is only the enabler. This is very crucial. You cannot let guys from the US or from wherever where they have implemented it say this is the way to do it. You need to figure it out here in India, what works best. You need to do the re-engineering of your own healthcare. And telecommunication can only be the enabler in making this happen. If you look to this environment as a telecommunication point of view, there are 3 fundamental things that you need to have. First of all is the infrastructure. Is it fixed broadband like the NKN that we saw this morning? Is it about wireless? Is it mobile? It doesn't really matter, but you need to have that infrastructure for you. Secondly, you need to be able to communicate. Is it voice, video, messaging, whatever it is. It needs to be there to make sure that you can collaborate. And the third sector is really about what also the previous speaker spoke about, is in fact, how can you connect these people? How can you connect the patients back to the doctors or to the health caregivers? And that can be through contact centers, video calls, whatever it may be, social networks maybe over time. But we are also able to in fact work on workflows, making sure that the patients are there in time, making sure in fact that the service is delivered in time. Once you have that fundamental building block, then all the other elements fits right on top of that. Is that tagging means just the location tracking, making sure that you find out where the doctor is, making sure that you know where even the beds of the wheelchairs are. It is all fundamental to have this in place. Now, if you have that connected healthcare communication platform, it becomes very easy to connect your clinical service, hospital service, whatever you have, into that. But of course, there's also the aspect of the patient. You have the patient communication. He wants to communicate back with his people back at home, at least leaving a message, making sure that he is taken care of. And if you look at that, that healthcare communication platform becomes in fact the spine of your digital healthcare delivering platform. And this is what the speech is all about. Quickly, some key technology enablers, and one of them is mobility. If you go to digital healthcare and go to digital medical records, how can you access them? In the past, when it was all paper, it was hanging in front of the bed of the patient. Easy, right? But the doctor had to get there and write all the notes. Now it's digitally. Then they invented something wonderful who calls a cow, computer on wheels. But that's not sufficient. And that's where we see where the tablets, the iPad history is in fact coming from. We see this going into the healthcare as a mass of speed, as a speed of light. Because that's going to be a platform who allow you, of a doctor, to have access permanently all the time, wherever he is, in corridors or whatever, to be able to monitor, to give advice, and to make sure that the patient record is up to date and that he can give the right advice. Secondly, patient engagement. Is it through satellite? Is it through voice? Is it through whatever channel it is? You need to make sure that you can make that connection with the patient himself. And even in some countries, we are talking now about social media integration as well. And being able to do that communication is fundamental if you would like to put the patient and the patient quality as number one. The third element is also fundamental in the sense that it talks about employee engagement. And this, ladies and gentlemen, is the core, the heart of your re-engineering process. If you give the instruments, the communication tools to nurses, doctors, and whoever who take care of the patient to communicate with each other, they're going to come back to you with, hey guys, if you do this or that, it will help me in giving a better service at a lower cost. We need to get that. You need to get to that level when you are able, with the caregivers, to come up with better processes. And this is the business re-engineering that needs to happen in the healthcare, and it will create also the innovations that is necessary. Of course, technology can help, and we have the solutions as workflow optimizations, where we're going to track and see where are delays. If a radiologist has finalized his report, how do you make sure that the doctor who was initiating that request get that message directly, real time? These are the things that need to happen and can happen if you have that infrastructure in place to make it work. We are going now to the next extent, where we try to put all these technologies, in fact, inside the service providers, so that the healthcare providers no longer need to think about these things. So as a small wrap-up in this sense, if you look to the hospital operations, a lot has still to do about silos. Once again, if you put that communication infrastructure, that platform in place, it allows you to interconnect again the dots, get rid of the silos, create that communication feeling, create the innovation and the re-engineering spirit that is necessary to implement the road to digital healthcare. So as a conclusion, re-engineering healthcare is the way to do. And this is the way how we're going to do the digital healthcare. That will allow you to reduce the cost and the time, who is so crucial for government and the amount of doctors we have to fulfill that. But at the same time, to in fact satisfy the needs of the patient, to increase the patient quality. And we as a communication provider, we can only be an enabler in helping you out, nothing more than that. And with that, I just want to end up what indeed, if you look to that telecommunication platform, we are really the spine to make that happen. Thank you very much.
Thank you, Dirk. If Dirk spoke about the spine of the healthcare system and about silos, I think we're comfortable with that, we in India. The next speaker, Dr. Arun Roy, is going to speak about transforming healthcare through meaningful use of IT. He is a Regents Professor of the University System of Georgia and Harkins Chair of Information Systems at Georgia State University, named Fellow of the Fellow of the Association of Information Systems in 2010 for outstanding contribution in research, teaching, and service to the information systems discipline. Co-founder of the Center for Process Innovation, has worked with major healthcare systems and IT-enabled services and process innovation. Over to you, Dr. Arun Roy.
Good afternoon. I'll try and stand a little away from the mic. Namaste. It's a real pleasure to be here in Hyderabad. And before I get started, I just want to thank the organizers for giving me an opportunity to participate in this great conversation, and for the wonderful hospitality, the amazing food, and the very kind weather in Hyderabad, making all of it very memorable. What I'm going to do today is hone in on one core message, and that is the potential of IT in healthcare or in any sector comes down to behavior of people, in that technology has to be used meaningfully to realize its potential. What I'm also going to develop by way of an idea in the next 12, make it 11 and a half minutes, is that in healthcare, you have a complex ecosystem of multiple stakeholders who differ in their social networks, their work practices, and their incentives. And in getting them to meaningfully use technology requires management of change and innovation by figuring out the mechanisms that get them to shift behaviors in a way that generates the value of IT. From a standpoint of the United States, where we've conducted a lot of our research, but with some very resonant problems with the conversation today here in India, you have cost, access, and quality problems. In the US, as has been discussed earlier this morning, our costs, of course, are greater than any other nation in terms of per capita costs on healthcare. And they continue to grow. They are responsible for 50% of bankruptcies in terms of reported bankruptcies. In terms of access, the uninsured and people who did not receive care is a significant problem. And then on the quality and the patient safety dimension, just to net it out, there is a 737 crash every day in the US. And this comes down to adverse events, medication errors, and such. Now, in terms of the potential of IT, the general premise for the IT optimists, and I'm one of them, is that IT can reduce costs, improve quality, and broaden access. And the mechanisms through which it achieves this is by coordinating patient care with providers, sharing information and processes, monitoring compliance, measuring and improving performance through systematic collection and analysis of data, and expanding access to the underprivileged in rural areas. But the reality on the ground today is, in the United States, only about 20 to 25% of US hospitals have an HIT system. More importantly, that's the number that have adopted an HIT system. When you layer in to the level of functionalities, what you find is the level of utilization in a meaningful way for core functionalities is very low. So for something like CPOE, computerized provider order entry, where you have standardized order sets and you're getting physicians and clinicians to use them, there are only about 14% that have reached stage 1 use as defined by the government. From a US policy standpoint, the response has been to hone in on this concept of meaningful use. And I will not belabor the idea, meaningful use is contextual, but they've identified a stage progression strategy for applications such as e-prescriptions, clinical quality of data, exchange of patient health information, hoping that they can get the country and hospitals across the country to stage through utilization of technology. And the levers that they're manipulating are standard policy levers. And you got the carrot, you got the stick. You know, you got good old Maslow's theory at work. And what you also have are the 4 major categories of technical assistance, expanding information exchange capacity. We heard a lot about capacity today. Deploying promotions, and importantly, establishing certifications and standards. But where policy has to meet practice, what we have by way of looking at it from an academician standpoint, I'm a researcher, so you basically step back and you say, what's the history that we have with technology projects that are large scale? And the fact of the matter is technology projects that are large scale can do significant good. There's no question about it. But we also have a solid history of failure when it comes to project implementations. So not only we have the dual issues of low adoption and problematic implementations, which have to be dealt with. Against this backdrop, what I'd like to share with you are some insights that we generated from one of our recent studies, which is now published in as a case study, and then there are academic papers, but the case studies available through the Harvard Case Repository. And this is in the context of CPOE use at Emory Healthcare. The CPOE context really is not pivotal to my story here. What's pivotal is understanding the calculus of adoption and use by multiple stakeholders and key stakeholders in the healthcare ecosystem. The first point I would want to make here is through our investigations, and we tracked several hundred physicians, about 1,000 I think, and an equal or larger number of nurses through the entire implementation process across one of the largest healthcare systems in Atlanta. And what we found was that you have both process benefits and switching costs that become considerations in the evaluation of net benefits. So focusing on benefits by itself is half the story. Switching costs is a very discretionary or important aspect of the computation. The point I'd like to make here right off the bat is this was a system that was fully supported by top management. Its use was mandated. But mandates do not make people use things in meaningful ways, necessarily. So just to assume that top management mandate and a requirement is going to lead to productive and the most meaningful use of technology definitely misses the mark. In terms of manipulating process benefits and switching costs, the 2 key mechanisms that we identified are transition support. Provide the technical assistance, provide the guidance, provide the support, resource the projects well, resource the transition to the new work process as well. Certainly, there is an emphasis on transition support because it's planned and it can be executed. But what we need to recognize is that each of these stakeholders are embedded in social networks that are very powerful. And what we have found is that the influence of social networks, the peers, has a dominant effect on both the process benefits and the switching costs. So the unplanned mechanisms, trying to get the social influence working in your favor during a change process becomes extremely critical. And this finding, or these general set of findings, replicate pretty strongly across technologies. Shifting just into some more granular insights, which I won't get too much into detail in the interest of time, is that transition support increases in importance with time. So resourcing a project just with transition support at the onset misses the mark. Again, social influence, people might think it matters only at the start of a project. But across a 24-month implementation, 24-month implementation of these systems, what we have found is that it remains important all through. The other thing is perceptions decline over time with some technologies. So, quite simply put, technology sometimes is perceived by key stakeholders as being oversold. Now, I've sort of drilled in on this point of social networks quite a bit. And what we have found is digital networks and social networks are very related. One of the studies that we did at a large Midwestern hospital systems, we came up with this very counterintuitive kind of result. And this paper is just recently published in the Journal of the American Medical Informatics Association. What we found there was that highly central physicians in social networks, people who everybody came to for advice and who were connected very well with other physicians for advice, and we focus on advice networks, were the least likely to use EMR systems. And as we drilled further in this, what we really found was these physicians who were well established really thought of the social networks as a substitute for the EMR systems. So they were relying on the social networks as channels for information. But over time, by getting these highly central actors into the implementation process, the story of the implementation unveiled in a fairly productive manner. Very quickly, we have done several studies in rural Georgia in terms of variety of applications, general routine, emergency, specialty care. And there's one key finding that we have from that in terms of the critical success factors. And that is that you have 4 broad categories that emerge. Technology, certainly. Individual factors, organizational factors, and partnerships. And it is the combination of these in a given context that becomes essential to manipulate and understand to achieve change. To sum it up, what I would submit to you is that realizing the potential of IT comes down to understanding and defining the idea of meaningful use in a healthcare ecosystem in a given context. And the policy initiatives and the innovation with respect to IT are obviously centrally important to the discussion, but also very important to the discussion and to the transformation effort is the management of change and the co-creation of value through partnerships between vendors and providers and among the set of providers. Thank you.
I'll stand here. Our next speaker is Professor Liao from the University of New South Wales, and he does one of the most difficult knowledge management jobs. He's a general practitioner. And I said to a friend who's a general practitioner, the morning surgery is one of the intellectual marvels of medicine, how you get through it at 10 minutes a patient or whatever you do and make so few mistakes. He said to me, well, if you think the morning surgery is good, you should see me when I'm getting tired in the afternoon. The pressure in general practice is terrific. You've got a broad research interest, I know, in this field. Professor Liao.
Thank you, Mayor. Yes, it's the afternoon. You still awake out there? Good. Anyway, thank you to the organizers for giving me the opportunity to share a bit of my journey. And I think it's a microcosm of the Australian journey. This slide is just a bit of background about my unit, which is the general practice unit at the University of New South Wales, highlighting my research program and our kind of vision of being a center of excellence in primary and integrated care. But it's essentially just a way to introduce the partners that we work with. Collaboration, you've heard a lot about it this morning. The Center for Primary Health Care and Equity, Asia Pacific Ubiquitous Healthcare Research Center, for that read Mobile Health, Australian Institute for Health Innovation, and one of our local health research institutes. And that's some of my team over there in the picture. Our focus is very clinical. It is based around trying promoting the use of ICT in healthcare within the framework of the chronic care model, which is essentially about networks, organization, and systems to support safety, quality, and continuity of patient-centered care. The idea is to get improved outcomes through producing an informed, activated patient who can interact productively with a prepared, proactive practice team, supported by, up there in the blue boxes, blue circles, health systems to organize the healthcare efficiently, the system design, decision support, and clinical information systems. And obviously in the community, you need to have good resources and supportive policies, along with programs to promote self-management. So some of our activities in these areas include, I guess, hospital systems as well as general practice systems, primary, secondary care linkages, and there's a strong focus on data quality because there's no point linking poor quality data because it's like the old GIGO concept, garbage in, garbage out. We have a program on clinical decision support and physician order entry with a focus on medication use, quality use of medicines. And one of our specific projects that might be relevant to this current conference is we're looking at safety of general practice clinical systems, trying to, well, along with others internationally, to develop an ontology or a classification of errors and risks in prescribing systems available to the clinician. For the patient, I guess we're working on using the Facebook platform along with the partnerships to promote consumer health informatics and promote self-management. Mobile Quit is a SMS-supported smoking cessation program, and this morning one of the presenters mentioned a mobile health program for the management of TB. We're actually doing something like that right now within the auspices of the Australia-India Institute. In fact, I'm heading up to Vellore tomorrow because the Christian Medical College is one of our partners in this. We're looking at data linkage and services integration as part of organization of healthcare. And obviously the people, the organization networking, trying to translate what we find in research into policy is very important. So that's a bit of background. And what's the Australian health journey been like? Compared to India, we only got about 20 plus people. So, but it's an easier place, but I think the lessons are similar. From the 1970s to 1990, we had a huge burst of activity in introducing ehealth or health informatics, mainly associated with financing and administrative systems to do with diagnosis-related groups. But the main message here is that during that last 20 years, that 20 years, we actually introduced clinical information systems and started to work with it. The next decade was what I would call, a lot of my colleagues would call the lost years. We call it pilotitis. I'm sure those of you who have been the victims of pilot projects will sympathize with me. In 2004, the Boston Consulting Group undertook a system-wide review of eHealth-related activities across all jurisdictions in Australia. They identified over 360 current or planned eHealth initiatives, and more than 70% of them were small, localized initiatives with a budget of less than $500,000. So that's a danger that I guess you need to think about as you start on your journey. The other thing is that the progress was too piecemeal and fragmented and lacked sufficient levels of investment and national coordination. Therefore, from 2000 onwards, we started to think about the coordination, and it resulted in a national eHealth strategy. So there were national projects to do with the GP computing group, which did a lot of work in general practice. MediConnect, which is looking at the national medication record. Health Connect, looking at a national electronic health record. And the Electronic Decision Support Task Force, which I was privileged to be a member of. And obviously, some of you may have heard of the National eHealth Transition Authority, which was formed in the middle of the decade to bring all the national standards together, develop them, and harmonize them with the international standards. And I think they're doing a fairly good job about that. Australian informatics research started to gather pace along with teaching, especially in the clinical context. The Australian College of Health Informatics was formed and was the beginning of professionalization of health informatics in Australia. So the Australian informatics technologies and companies were starting to mature. So I guess to a certain extent, the stars are aligning, and the social political environment is actually quite positive, a bit like the sensation we have had this morning. In 2009, the Australian National Health and Hospitals Reform Commission, the National Primary Healthcare Strategy, and the National Preventative Health Strategy identified that a national e-health records system and infrastructure is a key to building a 21st century health system. I guess this is rephrasing the work that's been done since the 1970s. In 2010, last year, the Australian health ministers reaffirmed that e-health will enable a safer, higher quality, more equitable, and sustainable health system for all Australians by transforming the way information is used to plan, manage, and deliver healthcare services. I'll just concentrate on one particular project because it's current, just to highlight some issues that may be relevant to the path, the journey you're taking yourselves. In April, our health minister, Mr. Nicola Roxon, launched a document in which she said that the Australian government is, investing about $500 million over 2 years to develop a critical national infrastructure. That quick. Which will give all Australians an opportunity from July next year, the option to sign for a personally controlled e-health record. This will enable better access to important health information currently held in dispersed records around the country. All right, it will mean that patients will no longer need to unnecessarily repeat their medical history every time they see a doctor or other health professional. I won't go into details of that, but essentially the personally controlled EHR will only collect personal information for the purposes of providing individuals with access to their own personal health information and enabling them to make their information more readily available to their chosen healthcare providers. There are a lot of issues involved, but it may be something that we can raise in the question and answer session. But I guess the comment to make here is that with Google facing or downplaying their Google Health program, I wonder whether we're heading where angels fear to tread. One of the implementation strategy, the implementation strategy is to work in partnership. A national infrastructure partner, a benefits evaluation partner, and a national change and adoption partner. Okay, and I won't talk about change management because change management has been discussed earlier this morning. But some issues to beware. And the hypothetical that was conducted this morning highlighted that IT solutions should not undermine the patient-doctor therapeutic relationship. We do that at our own risk for the reasons that was mentioned. Empower patient does not mean improve quality or quality of information or care. And there is an explicit business case to be made across the care continuum because what affects one part of the care continuum might not have good impacts on another part. Like, for instance, the data collector, namely the clinicians, do not benefit as much as the policymakers or the managers from data collection. So there's a whole bunch of other issues. But finally, I guess a number of international studies suggest that a middle-out approach based on collaboration between government and the ICT industry and healthcare providers to create an evolving set of standards and promote dialogue across the sectors is likely to be more effective. I would have added patience in there, but there's no evidence to allow me to make that statement, which is a sad reflection of how patient engagement has been. So with that, I say thank you.
Ready, Clint? Are you ready to go? Our next speaker is from the United States, and there's one great tradition in the United States, and that's the seventh inning stretch, where people stand up after seventh inning at the baseball. So I'd like you all just to stand up for a minute. You've had an hour of talking so far, so stand up and stretch while the next speaker comes up. Stand up now, you must stand up and stretch. Okay, Clint? And Clint works for Qualcomm, but equally or even more important, he's the president of the Continua Alliance, which is trying to make sense of the common standards so that these things join up with one another. Clint, are you ready to go now? Thank
you very much. I had a little demo issue there a moment ago, but we straightened it out. First, I want to thank... Oh, let's get that there. Oh, there we go. Oh, still not there. Oh, there we go. First, I want to thank the organizers and Apollo for inviting us to speak today. It's a great honor to be over here in India as the health system is, and everyone is really looking at how do we improve and bring better care around. I had the great privilege probably 15 years ago of being one of the world's first wireless analysts. And at that time, I remember cellular was just being deployed. It was maybe 1995, and we thought, gosh, what's going to happen with this cellular technology? We weren't quite sure. I'm not an engineer, but I thought, let me get this straight. I can make a phone call, wherever I am. There's something very remarkable about that. And so I also had the great opportunity of being here in India when cellular was taking off and speaking to the DOT, the Department of Telecommunications, and others talking about cellular. Little did we know it would become as prevalent as it is right now. So right now, everyone, I'm pretty darn certain everyone in this room has a cell phone. How many of you can get one email account on your cell phone in the room here? We would have never thought that 5 years ago. How many of you can get 2 email accounts on your cell phone? That's absolutely remarkable. You can be in contact with anyone, anywhere on the planet right now. And with multiple modes, call them, email them from a different account, text them. So from this, we have a tagline, and I love the Apollo tagline, which was a billion hearts beating. We have every body on the net. And now we're at the point where these are computers we have with us. It's not just a phone. Now what can we do with it? And this is the next value we need to bring to this phone. How can we use it to manage our health? And so I have a demo right now I'd like to show you, and this is what we just got running.
Yes, it should come.
Okay, how do I get that larger again? Oops. What did I just do to it? There we go. How do you make it?
It's big on this.
Yeah, how do you get it big? There we go. Okay, great. So what you're watching up here right now are my biometrics. That's my heart rate, my breathing rate, and I also have a couple of other tools. I can upload my SpO2. I can upload my blood pressure as well. I'm wearing a biometric harness that was used with the Chilean miners that were recently trapped. They dropped these harnesses down so they could watch their biometrics. So this harness is transmitting to this phone. This phone is transmitting to the cloud, Maryland to be exact, and it's coming all the way back via this PC to look at my biometrics. So this is absolutely remarkable when you think about it, that someone anywhere on the planet can take a look at what's happening with me. So there are many different use cases we're looking at. One is that with this phone and with this kit, I can manage my health better. And that's going to be a big key to this. The way health care has to transform is that we need to take better care of ourselves. Lots of disposable income goes out for the healthcare system or the sick care system. You usually go when you're sick. So how can we keep people out of the hospitals? So one manner would be to have applications that help us manage our health. The next piece that we will see this year is that emotional component. What's going to make you want to do that? There are lots of gaming companies that are getting interested in this. How can I upload this to Facebook and maybe compete with my twin brother? Maybe I have a lower average heart rate for the month. I don't know what it might be, but there are lots of different competitions you could see. In Mexico not long ago, we went to see how we could help with diabetes up at a little village. Well, there were 4 women who had a little help group. They actually helped each other out. So that was a way of actually the social interaction. So if you have a chronic illness, how can you get together with others and electronically help manage that health better? So one would be managing our own health. The other would be, especially here in India, taking a phone with a set of sensors, blood pressure, cuff, a glucose meter, a weight scale, and maybe setting up a clinic in a remote village, maybe going door to door. What we will do there is we will find people early, screen early for hypertension, for diabetes, and completely change the landscape. Not everyone will afford one of these. We know that. But if you can create a distributed model, that's another way to do it. And so what we're seeing here is that if I were a caregiver with this system looking at a patient, this could be someone back at Apollo hospitals helping that person manage that health. So what we're going to see, this is going to be the year when we start to see more solutions actually coming out and using the cellular systems. And towards next year, the early next year, we will begin to see these systems start to be deployed. And then what we're going to find, just as when I was a cellular analyst 15, 18 years ago, when we never saw what these phones could do, we're going to have a tremendously exciting period where all kinds of different companies come in and try to figure out how to make businesses out of this, how to bring the emotional component in, how to drive this. Again, the technology's here, and within the Continua Health Alliance, what we're working on is making it easier to pair these devices. As you probably know from a Bluetooth headset, Bluetooth is not the easiest technology to work with. So within Continua, we developed a health profile to make it easier. Then we have Bluetooth Low Energy coming out very soon. So what we're trying to do is to ensure that you can assemble these quickly, efficiently, but then also these systems transmit back from the phone to an IHE HL7 format so that you're basically creating an end-to-end clinical system. So by deploying these Continua devices and services now, you can future-proof as we begin to get the HIT systems normalized and we begin to get interoperability. So again, thank you for having us, and enjoy the conference.
That is really technology at its best. Thank you, Neil. Right now we have, I think this has been a truly international panel here. We have speakers from the United States. We had from Australia. We had from, Denmark. Of course, our star speaker is here, Sir Muir Gray. But right now I have somebody from South Africa. He's Dr. Maurice Mars. He's a medical graduate from the University of Cape Town. He's an MD, University of Natal, President, South African Telemedicine Association, Professor of Telehealth. Then he's in the Ministerial Advisory Committee on Medical Technology, the African Union and Health Experts Group. He has chaired the Educational Committee of the Innovation Society of Telemedicine in Natal. So I request Dr. Maurice Mars to grace the occasion.
Thank you very much, Chair. I need to thank the organizers for, in fact, inviting me. I've purposely put up a slide of something with a long neck because I intend to stick my neck out a bit. The first challenge that I have is to the, in fact, previous speaker. I think everything that we saw was fantastic, except that in sub-Saharan Africa, internet penetration is only 4.5%, in fact, percent. So you've got a long way to go before, in fact, you get to, in fact, all of us. Okay, I think that in order to tell the story about South Africa, and I could stand here and I could tell you 8 or 10 success stories, but there ought to be 80 or 100 success stories. So I need to go on about, in fact, where we came from, where we're at now, and where we hope we are going. So first of all, South Africa is at the bottom end of Africa, and we're linked to India by the warm seas of the Indian Ocean. We're a medium-sized country, about, in fact, 50 million people, half of whom are urban, but almost half are under the, in fact, poverty datum, in that line for South Africa. We've got 9 provinces, and we have 11 languages, which, in fact, causes a problem. But we have an excessive burden of that disease. Up until a month or two ago, we had the most people, in fact, living in the world with HIV. We are dying at a much earlier age. We have rampant TB. We have rampant MDR TB. And we now have a problem of XDR TB, which is going up all the time. In fact, government spends 8.6% of its budget on health, and it immediately devolves that down to each of those 9 provinces, who then fund and run the public health system. Now, the public health system services 82% of the people, but 60% of the total health spend in South Africa is spent on the 18% who are in the private sector. There aren't enough doctors, and there's certainly not enough doctors in the public hospitals, and half of all the posts in the public hospitals are in fact vacant. So if ever there was an environment where telemedicine is needed, it is here. The next problem, the country is growing faster than we can supply power. Internet penetration about 11%. Fixed broadband less than 1%. So how do you hold IP-based video conferencing? The cost of broadband based on a package dealt with by the ITU is about 5 to 6 times that of England, Australia, Germany, etc. But fortunately, we seem to be approaching virtual saturation with phones, and that may be a saving. So going back in South Africa, we began effectively in about 89, 90, linking some CT scanners back into the medical school. In fact, change of government, there was an immediate identification of the need for telemedicine to service the poorest of the poor in the outlying areas. So, in fact, National Telemedicine Task Team was established in 1998, and in 1999 launched the first of 3 phases of a national telemedicine project. 4 areas were looked at. The 4th area, teleophthalmology, actually just didn't ever get going. Why? Because the software was black and white instead of being color. In 2001, a paper came out asking if it was a success or a failure. It was a huge failure, full stop. A single sentence in the paper hides all sorts of important messages. The project was conceptualized nationally, centrally. It was dropped in to each of the 9 areas with the expectation that the local provincial ministries of health would then fund it, would find posts, and would be able to keep this thing going. In fact, January of 2011, only 2 of the 9 provinces had people employed doing this. Only 2 of the 9 provinces have a budget for in fact, telemedicine. So we then went into the next phase where there was virtually nothing happening. So we attempted in 2006 to form a in fact, national association, and were actively blocked by the National Department of Health, who attempted to take back control of this and drafted law for, in fact, telemedicine. The Health Council of South Africa then drafted guidelines for, in fact, telemedicine. Fortunately, these have not surfaced because they were both badly developed. We had a change in the National Ministry of Health, and suddenly there was an enthusiasm again. So the messages don't fail first time. It takes 10 years before people have the confidence to, in fact, come back to you. So a draft ehealth, in fact, strategy and a draft telemedicine strategy were developed around April, May of last year. And unfortunately, we had a change of, in fact, minister, and they've gone back for a second draft. And in an attempt to get things going, and in fact, advisory committee has been formed. But the National Department of Health conducted an audit in January or February, and they said that there are 89 sites in South Africa where there is telemedicine. In fact, note the term sites. It's not services, because there are plenty of sites, there may be 4 or 5 services. But the next problem is that they said there are 85 sites, but only 35 of them are actually active. Now, that is incorrect, because in our region we have 40 sites, and all but a single site is up and working. The second thing, it makes no mention of, in fact, store and forward services. In fact, store and forward dermatology, ophthalmology, orthopedics, we've been doing that since 2003, and it in fact isn't shown. The next is it makes no mention of, in fact, teleeducation. And it's important that one understands that there's very little that is new. The first closed-circuit TV education in fact, psychiatry was in 1955. In 2010, in fact, the Department of Telehealth in Durban broadcast 4 hours a day, 7 days a week, in fact 365 days a year. So in fact health information systems, in fact 9 provinces have 6 different systems and they don't speak to each other. The National Health Lab Services have a system which speaks to some of them. We do have a functioning district health information system. In fact, government is planning on implementing a national health insurance in fact, 2.5 years' time, which needs an electronic medical record, which we don't have. Now, the interesting thing is that if you move out of the government sector, go into the private sector, they have everything and they make it work. Yes, there are a number of in fact, isolated successes, and we saw an example in the second session this morning. Some of the interesting projects which in fact have worked, there is a TV-based health education system which is beamed into hospitals. There's a TV set in the outpatients, and in fact patients see this every day. I think there are about 180 sites. In the private sector, as we've seen here in fact India, there is success. There is successful teleradiology, etc. Now, the people are making it work because they have to earn from it. In the state sector, people are salaried and they don't have to do any extra work, and it's hard to actually implement these services. So I think that we have a lot to learn from the private sector, both in South Africa and the private sector here. And again, the word ehealth is a brand new buzzword. The first ECG, and there we see Eindhoven sitting in his device, in 1905 sent his first ECG over the phone lines. So the, in fact, simple device has been developed in South Africa, and it works effectively. It sends messages if the patients don't take their meds. A message is sent by SMS onto the patient. If the patient doesn't answer, an SMS is sent off to a family member or friend who then goes and in fact finds the patient. And that's been very successful in making people take their meds for, in fact, TB. Cell Life has been a success, phoning patients with HIV, in fact, giving them advice and, in fact, helping them in various ways. In fact, a local company has developed a teleaudiology setup, which is now being used within Africa. In fact, we've developed a local homegrown telemedicine unit for clinics. Arms Corps has developed a, in fact, mobile lab which can be moved into any area that's needed. We've been fairly slow in the academic world. We formed the Department of Telehealth in 2002, and we have postgrad programs in both telemedicine and in medical informatics. And of the 8 medical schools, there is only a single other medical school that, in fact, offers anything in this field. The, in fact, South African Telemedicine Association is new. We formed in August of 2010. We are an affiliate of the International Society for Telemedicine and eHealth. We're fortunate, and we have members from all the various sectors. And our first focus is to get an enabling legal and regulatory environment that will enable us to take eHealth forward. The second focus that we have is to develop guidelines so that our people aren't exposed and saying that you're practicing bad medicine because there aren't any guidelines. And I'm very pleased that in the first 6 months we've managed to get guidelines for, in fact, telepsychiatry, which are in the process of being endorsed by the in fact, College of Psychiatry. The second thing that we've done is we've formed 6 special interest groups, the aim being to fast-track telemedicine in these fields. And the first 2, as you'll see, are in fact legal and ethical, but the second is eHealth economics. And we feel that we really have to understand that. The next thing that we want to do is to develop a national research agenda. We in fact are conducting surveys, we're developing capacity by going out and training, and we look to form international links with countries like India. So, in summary, let's just look at that picture. Is that a sunset or a sunrise? It's the sun setting on the old telemedicine in South Africa. It's the sun coming up on the next 5 to 10 years of hopeful success. And I'm going to finish by inviting all of you to come to Cape Town in September. A fortnight ago, we were asked, in fact by the International Society, if we could take over the meeting in September. It was supposed to be in South America, and there are some difficulties there. So, in fact, Stellenbosch, it's in fact next door to Cape Town. They harvest excellent grapes, they make excellent wine, and I invite you all. Thank you.
Thank you, Dr. Morris. I wish to thank Dr. Ganapathy for giving this opportunity to co-chair with one of the major persons in the National Health Service, Sir Muir Gray. As you've seen, he's bubbling with his enthusiasm, and it's very, very inspiring, sir. He would want the audience to be interactive after this session. He would basically be interacting with you on the future of health. He's the Chief Knowledge Officer of NHS. I had the privilege of studying NHS when I was studying as a Shivaning Gurukul Scholar at the London School of Economics. And today I could share the dais with him. It's a great privilege. Over to Sir Muir Gray.
The future is not like Mount Everest. Future is like the Taj Mahal or this conference center. It's something we imagine, plan and build. If you do not imagine, plan and build the future, then other people will do it for you. The other thing about the future, and I'm going to tell you about the future, is, in the words of William Gibson, the future is here. It's just not evenly distributed. So everything I'm going to say, I can see somewhere. Now, you can always see a single word summarizing what we feel about healthcare internationally. In the 1980s, the key word was effectiveness. That was when the Cochrane collaboration started. In the 1990s, cost effectiveness. And then the last 10 years, it's been quality and safety. But we've reached the end of the era of quality. Quality is important, but the key word for the next 10 years, in fact, I can predict for the rest of the century, and none of us will be here to prove this wrong in 80 years' time, but the key word is value. This is the value century. Now, what do we mean by value? Value is the relationship of outcome to costs. Now, outcomes is good outcomes minus bad outcomes, or effectiveness minus harm. And the other conference has been on safety. So quality is very important, but only in that it gives good outcome. And quality improvement always has to be related to the money. So the money you spend in quality and the money you spend in improving safety has to be judged with what else you do with the money. Because the cost of healthcare is not to do with money. Money is simply a means of transferring wealth. It's the cost of carbon, and carbon will become an increasingly important resource in all health services in the years to come. Hospitals in England are already being fined if they exceed their carbon budget. And the other cost is the opportunity lost. If we put more money into cataract operations, then that means that money cannot go into diabetic retinopathy or glaucoma or macular degeneration. So we're entering the value century. And here's my little book on how to get better value healthcare. And when I published this book 5 years ago, my wife said, no one's interested in value. And I said, not yet. But every health service in the world is going to have a crash. There's a film called Unstoppable at the moment. And we're heading towards a severe crash. We have to think about value. Now, I find it helpful to think of us being in the third healthcare revolution. So the first healthcare revolution was the revolution of public health, of clean water, of better housing and better food. And that still takes place. For us, the public health revolution is to do with smoking and diet. The second healthcare revolution, which you can see on the right-hand side, we've experienced in the last 50 years, and it's been fantastic. MRI, stereotactic radiosurgery, transplantation, coronary artery bypass grafting, the randomized trial. These have been high science developments. But at the end of 50 years of fantastic progress, every health service on earth faces these 5 major problems, still has these 5 major problems. Harm to patients, variation in quality and outcome, waste of resources, inequalities, and failure to prevent disease. And there are 4 new challenges coming. Population aging, rising demand, carbon challenges, and financial challenges. Now, what we tried in the 20th century, we tried 5 things. And these are all necessary. Policy making, management, regulation, research, education. But at the end of 50 years, we still have these problems up here. So these haven't solved things. So I'm going to tell you about the next 50 years. And I'm not going to mention the word IT anymore, because my experience has been that when you're trying to do something, there are always 3 issues: managerial, cultural, and technical. And it's never a technical problem. I mean, if someone can monitor their heart rate and send it to Maryland and bring it back for us to see, you guys can do anything. The question is, can we get particularly the clinicians to say what it is they want to do? In fact, I don't use the word information systems either. I say, what's the clinical system? What's the clinical system for epilepsy? How do you manage epilepsy in Andhra Pradesh, or in Oxfordshire, or in Manitoba? And clinicians can't tell me. They tell me every patient's different. Well, I know every patient's different, but what's the system? So, I'm not going to speak any more about those 2 words. Here's the first thing. Here's 5 things. Here's my prediction of 5 things. I'm just looking at my timer here. Here's the 5 things. Firstly, systems and networks. Why is it we know to the nearest pound what we spend on every hospital, and not to the nearest 100 million what we spend on rheumatoid arthritis, or depression, or headache? And here's the language of the 21st century. System, network, pathway. System, network, pathway. Here's a system. A set of objectives with criteria, outcomes, and standards. And that's more 21st century language. Objectives, criteria, outcomes, standards. And here, this is very similar to Dirk's picture. It's not run by hierarchies. It's run by networks. And networks are a set of individuals and organizations that delivers the system. Number 2, transparency. We publish an atlas showing how all the health services in England compared with one another. And in a way, everyone knew it. But when they saw it on paper and on the internet, and they saw that they were doing 3 times as many operations in one population as other, people were astounded. And I'm thinking of a atlas of Tamil Nadu, or anywhere you look, there are huge unwanted variation. We are also very interested in variation in quality and outcome. And in 10 years' time, there will be ratings on every doctor available on the internet. Because what we're seeing is a revolution. One thing we're giving citizens, wherever there's phone access, and I accept the point about Southern Africa at the moment, but this will change. This is the technology. I don't know about I'm not very technical at all, but this is the technology. And they have decided we're all going to have smartphones. You know who they are? It's not world government, it's Nokia and Vodafone and these people. They have decided this is going to be standard. So here's what we're giving. If you type into the World Wide Web, www.nhs.uk, you don't see a picture of headquarters or committees. You see this, knowledge for patients. We've given the public the Cochrane reviews. They're going to find rubbish on the internet, so why don't we compete on the internet? So we give them best current evidence. We're also empowering citizens because we're giving them, this is a service which provoked horror among the medical profession, allowed patients to give feedback on individual doctors. But this is now becoming standard in the United States. You see, with this, people are rating everything. So the medical profession has to understand there is a revolution taking place, and it's got to get up to speed with it. So these are the things that will happen. The 20th century was the century of the doctor. The 21st century is the century of the patient. And this is the mediator. Revolution comes out of the smartphone. And finally, culture change. Now, culture change, culture is the shared tacit assumptions of a group. Or that's the formal definition by the guru Edgar Schein, but it's the way we do things around here. And you all know how the culture of one hospital is different from another. But we need to change the culture. One way to do that is to get people to use a common language. And I always say I don't want to manage people, I just like to influence how they think. So if you asked everybody in this room, or even on the panel, to write down the difference between efficiency and productivity, what would we write down? Something different. How can you can't run an organization without a common language. So what we're doing is using, from the Better Value Healthcare program, we're delivering not only books as Kindles, but we're doing podcasts. I happen to think you should all read this book. This is one of 10 books you should all read. But you certainly need to know there was a man called Avedis Donabedian, and he invented structure, process, outcome. This is culture. Culture, of course, is not only language, it's language and leadership. And we heard Dr. Reddy this morning giving a perfect example of leadership. And one of the jobs of the leader is to shape and manage the culture. So leadership and culture can be influenced through the World Wide Web. And just to finish, I'm a veteran of, I think, 20 reorganisations of the NHS, and really none of them have made any difference. Structure doesn't matter. The reason we know structure doesn't matter is that every health service in the world faces the same problems. Safety, waste. That's 11 minutes, I'm well ahead of time. Every country in the world faces the same 5 problems, whether they're tax-based or insurance-based, public or private, co-payment or no co-payment. Markets don't solve this problem. Bureaucracies don't solve this problem. What we're trying to do is too complex for either markets or bureaucracies. You have to have both. But the model for me is the ant. Ants are fascinating. Ants are the most successful species on Earth. Ants don't have a bureaucracy. They don't have a market. But when something happens, the ants get together and they solve the problem. And they learn. An old ant colony is cleverer than a young ant colony. So here's my hero, the leafcutter ant. So for the future, we need to think of working together. Collaboration and competition. And this, I will use the word information technology, but it's this really. That's all we need to know. The technology, the clever people can work out what goes on inside it. This, the health revolution, comes out of the barrel of the smartphone. Thank you very much.
I am going to give a big hand to Sir Mayor Gray. A bigger hand. Because he put an entirely, totally new spin on technology. He says that the message is more important than the messenger. And we talk more about the IT infrastructure. He's more into the concept. There's a love letter from Dr. Ganapathy. He says, there will not be a formal tea break. For those who are famished and thirsty, tea and coffee will be served on the sides of the hall. The next session will start immediately after the mementos are distributed. Thank you.
No. Before this, we'll have some question and answers requested by Sir Muir Gray. And may I take the privilege of asking you a question, sir? I belong to the BC era, before computers and before Christ are one and the same. I was the last group of neurosurgeons in this country who were trained before the CT scan came. Obviously, I am a technology enthusiast, otherwise I wouldn't be here today. But I'm really concerned that today's generation, not only of doctors, but of everybody involved in the healthcare ecosystem, are not using technology as a means to achieve an end, as an enabler, but are seeing technology as the ultimate goal. And today, you want a gamma knife, you want a 5 Tesla MRI, you want that and this, purely to increase the visibility of an institution. And today when a patient comes with headache, the present average doctor doesn't even listen to the patient, ask the history, doesn't physically touch him, but asks for a CT scan. And the patient retorts and says, what do you mean CT scan? Doesn't your hospital have an MRI? So this is the true world, and particularly with Google has caused us a lot of problem. Today the patient who comes to me knows slightly more than what I know about the specific disease which he has, because he has all the time in the world to Google, which I don't have. So I would like to have your comments on this, on whether we are dehumanizing medicine in the form of using the smartphone, of which obviously I am very passionate about.
In the road ahead, Bill Gates writes, the key question for the organization in the 21st century is, what is the function of the human being? Not what is the function of the technology, but what is the function of the human being? And at the heart of healthcare, there are two human beings, the person called the patient and the person called the doctor. Firstly, the person called the doctor or the nurse or this fantastic person you're developing in the Rural Health Mission, the ASHA, what do we want that person to do? We want that person to be sympathetic, caring, and to listen to the patient and to examine the patient. That's the number one thing. That's what human beings still do that better than machines, although we're seeing how machines can help with that. So we have to focus on the nature of the discussion, and it's the communication skills. The main weakness in clinicians in the 21st century is not their inability to manage technology, it's their inability to communicate. We've just published a book called Better Doctors, Better Patients, Better Decisions with my colleague Gert Gigerenzer, and Gert has shown that doctors do not understand probabilities any better than patients. So, firstly there's the doctor. We need to go back to core values of being a human being and caring for another human being. Secondly, the patient. I was once at a meeting where someone said a politician had asked him to introduce legislation to control the internet. And he said, that's not possible. And he said, well, could you draft legislation to make it look as though we're controlling the internet? The internet is uncontrollable. But that means that healthcare then has to look at the job of the patient. And what I believe we should do is, someone like Apollo could do this, and maybe you are doing it, is send your own version of the evidence to the patient before they come. They will still go and look up Google after that. But we in the health service in England, we send out 1 billion letters a year, and I have not yet found one in which we've put the knowledge that we have in that letter. And the job of the patient is to look after themselves, to look on the internet to see what they can find. But the job of the patient is as an equal in the consultation. And I think the issues that came up in the safety conference, we have to be absolutely honest with people, and they need to know that technology has a downside as well as a benefit. So that's my view, is that technology is irrelevant, it is a delusion, but I think we should finish by asking each of the panel members this question about the human being and the technology. And I think you can use have we got a microphone each of them could use? Could we start with you, Aaron? Could you try and use that microphone?
Can you hear me? No.
Maybe you'll need to come up and we'll finish with one comment from you, Aaron.
Thank you. Is that clear? Yeah. I'll just make a quick comment on that. It comes down to what I think is the difference between substitutes and complements. If, in a good way, the technology complements the human being. And I think at the essence of the question that was posed, technology became a substitute. And I think those are two very fundamentally different ways to view the role of technology in healthcare. I'll just leave it at that. Thank you.
I think there's
a great amount of truth behind what you're saying. It's the humanity, the people the relationship between the doctor and the patient, who is really fundamental and central. And it may be sad to say, but if you look to all the re-engineering jobs that has been ongoing, I think the last battlefield is in fact the battlefield in the healthcare. There is a big re-engineering job that need to happen there. And the doctors really need to open up and start to talk with the patients and come to the same level with the patients. I know it's a difficult task. It's a task going to take maybe generations to build. But you are absolutely right, Dr. Harapati, that in fact the people, the patient you're going to have in front of you, going to be knowledgeable about the disease. And I have a personal, let me say, experience when my daughter died, that we know what it is to be a doctor. The doctor don't know all the answers either in life. It's really, if you have that trust relationship with the doctor going to tell you as well, sorry, I don't know anymore. That's where I can go. The rest is guessing, guesswork. And then you can work really, once you achieve that between a doctor and a patient, then you can work together, hand in hand, to understand what are the options, the possibilities you have. And then you go through that path and you make the decision, does it make sense to have in fact a patient suffering for 1 week, 2 weeks, 1 month in a therapy, maybe going to extend his life for 2 years, then it makes sense. Is it for an extra month? Maybe it doesn't make sense. But these are the decisions that need to be made between doctors and patients. It's really about that relationship. And technology has absolutely nothing to do with this. Absolutely nothing.
I think I agree what Ganpati has said. The technology should assist the medical fraternity. It should not replace the medical fraternity. And gradually trend is what is coming, that we first see the patient's face and order all kinds of diagnostic and then make our diagnosis, not even using our clinical acumen, which is a very dangerous sign. So the technology, what it may be robotic to the IT or anything, should assist the medical fraternity and it should not be replacing. And that is what the mindset medicals have, that this medical technology one day probably will replace us, and that will be disaster.
A mentor of mine, David Sackett, was trying to explain evidence-based medicine to me, and he said, evidence-based medicine is about applying the evidence but guided by the patient. And I guess as part of my presentation, I tried to highlight the fact that we should not undermine the doctor-patient relationship as part of our embrace of technology. As many of you and many of the speakers have said, it is just a tool. And it's not the only tool. There are a whole number of other things, as Samuel Gray says, is managerial, is organizational, is social, is ethical, is legal, a whole lot of other stuff. But at the end of the day, there is an information explosion out there. Some of you, you mentioned, Professor Ganpati mentioned Google. Now, some of you may have heard of 21andMe, which is the genomic testing over the internet by, well, obviously run by a company that's controlled by Google. And one of the things we found that is that we still have to explain the results to the patient when they do their stuff online. So at the end of the day, if you look at it is not just about the doctor, it is about the healthcare team. At the end of the day, we want an empowered patient, and we want a proactive and empowered practice, a team of healthcare providers that can work with the patient interactively and together analyze the evidence and make it relevant to the patient. It's not, kind of guesswork. It is actually trying to apply some of the evidence but taking the patient context into mind, into consideration as part of the total healthcare team-patient relationship.
It is an interesting point, and I'm sticking my neck out again, and I'm going to say that I'm hearing developed world speak. In fact, 2/3 of African countries have 10 doctors or fewer, so the issue isn't necessarily over interacting with the doctor, it is, do you have a doctor? The second question, and we need to think about this seriously, is, should we have technology or should we have tablets for sick kids? So I think we need to just think again. All of us are enthusiasts about technology. We want to see telemedicine work. We want to see it advance everybody. But we need to remember the poorest of the poor, which is the group that we most have to serve. And the challenge that I put out again is this, that home care is going to probably be a wonderful advance for the developing world, the poorest of the poor, because we must adapt one-to-one care to one-to-many care and take advantage of that. And I think that we need to be careful in meetings such as this, where we're all excited about the technology, to just bear in mind the poorest of the poor who actually need it. Thanks.
From our perspective, technology should make the life of the doctor easier and the life of the patient easier. Probably about 3 years ago, I was visiting a company that was experimenting with, it was a research company. They were building a pillow, a pad that would measure ECG and heart rate, and their idea was that you'd take this pad and you'd put it on the back of your chair, so at night when you came home, you'd sit on that and it'd give you some vital sign feedback. Well, one of the guys, when they were experimenting with this, sat down, and he's not a cardiologist, but he saw 3 peak waves. Like right here, you see a nice single peak wave. I'm not a cardiologist, but I've seen enough TV shows to know you get 1 peak wave and a lower one. I can even hear it right now as I think about that. Well, he saw 3, and it saved his life. He went to see a cardiologist, and he was about to have a major heart attack. So from that perspective, if we do have tools that we're using to help us monitor ourselves, I wouldn't know what a good peak wave looks like, but you can build algorithms that would look at that and say, call your doctor. There might be something there. The way we look at it is it's kind of like the black box in an airplane. When you're using these systems, there's a lot of data coming through, and this is what doctors are afraid of also. If the data is normal, it looks good, just keep throwing it out or storing it, but when you see an event, that's when a trigger occurs. And what we need to figure out is how to alert that patient. It might be just, hey, call your doctor. But we're confident that these types of simple systems will absolutely save lives and help us manage our health better and actually make the doctors' lives easier, we hope.
And now, ladies and gentlemen, I request the chairpersons, Sir Moore Gray and Dr. Santosh Babu, to give away the mementos to the panel of speakers. Could we please have the mementos? Ladies and gentlemen, let's have a round of applause. Ladies and gentlemen, allow me to invite Mr. Sanjeev Zuchi, the CEO of Medversity, to give away the mementos to our chairpersons of this session. Please give a huge round of applause. Thank you to all the dignitaries for a very thought-provoking session.